Hello, my name is Juebin Huang. I'm a faculty neurologist in Department of Neurology, UMMC. I'm gonna be starting to talk about movement disorders, and this first lecture is an overview of common phenomenology of movement disorders. By definition, movement disorders are a group of neurologic conditions that may affect the speed, the fluency, quality, and the ease of movement. Typically, the movement disorders are a result of dysfunction of the extrapyramidal motor system, not because of weakness or sensory deficits. This abnormal influency or speed of movement may involve in excessive or involuntary movement. We typically call it hyperkinesia, or slow or absent voluntary movement. We call it an hypokinesia, or in the extreme case, akinesia, or sometimes called bradykinesia. Hyperkinesia, again, it's an excessive or involuntary movement, and it's that those type of movement you don't want it, but it's there and out of your control. On the other hand, hypokinesia means the movement is very slow, or there's no movement when you want to carry out activities. The causes of movement disorders, it's very complicated, but most of the movement disorders are associated with the pathologic changes in the basal ganglia area, as you can see in these slides. And basically consists of chordate nucleus, putamen, and globus pallidus, and subthalamic nucleus, as well as substantia nigra. How does the basal ganglia work? Typically, when a motor command in the cortex is sent to the basal ganglia, it gets amplified, and then the signal is then sent back to the cortex. This process is controlled by dopamine. Whether the signal is increased or decreased, and dopamine has something to do to say that. Over time, dopamine teaches the basal ganglia which signals to increase and which to decrease. So what goes wrong with movement disorders? It turns out that too little dopamine or any kind of injury to the basal ganglia, and that the output may be too much or too little, and then too little output turns into hypokinesia. Too much output turns into hyperkinesia. This slide shows very common used categorization of movement disorders. As you can see that we said the typical movement disorders are basal ganglia disorders. It can be divided into hyperkinesia, means excessive movement, and hypokinesia means reduction or absence of movement. There's also some other movement disorder cannot be classified as hyper or hypokinesia is listed here. We're going to focus on hypokinesia and hyperkinesia and the common symptoms in the next couple of slides. Hypokinesia syndrome, and we use the term Parkinsonism and to describe a lack of movement. It's a syndrome characterized by combination of tremor and hypokinesia, rigidity, and posture instability, any combination of that. But it's a syndrome. It's an umbrella term. The underlying cause of Parkinsonism are varied from patient to patient. And this slide also say that the typical posture of a Parkinsonism and the lack of movement of the arm swing, and you can see this patient, the arm actually flexed in front of him. So some common symptoms of hypokinesia include rigidity, which is increase in resistance to slow passive movement. Typically, you move a patient's arms and leg by telling the patient, don't do anything, just let it loose, and then you try to check to say if there is any resistance while you're doing the range of motion movement of the patient's joint. This type of rigidity can be accentuated by movement in opposite limb. This is called the Froment sign. Rigidity can be lead pipe or cogwheel, type of rigidity. Even though rigidity can be detected by clinicians in the office, and sometimes can be much more severe than other times, but rigidity itself usually is not a major source of disability. We're going to talk about what's the major source of disability later in the next slides. So akinesia or bradykinesia describe the slowness, the fatiguing, and the motor arrests in ongoing movement. It affects the speed, amplitude, and rhythm of the movement. And this is the symptoms that mostly disabling, and it causes the patient to mobilize very slow and to cannot achieve the amplitude or distance they're trying to, and to have difficult initiation, movement, or turning, or get in and out of car, and so on. Posture disturbance is another symptoms of hypokinesia, and usually the typical posture of Parkinsonism is a flexed posture, the so-called Simeon sign. Patient can present with posture instability. It means the patient is not able to maintain a specific posture without falling forward, which is a proportion, or falling backwards, the so-called retroportion. That leads to falls, and also while the patient working, the patient can present with a shuffling gait, sometimes with the in the disturbance while walking called freezing, and means the moments the patient try to move, but the feet sticking on the ground and cannot get it moved. Here is some conditions, some pathological conditions that can be classified as Parkinsonism. As you can see that Parkinson's disease, it's probably the most common Parkinsonism, and oftentimes we call it idiopathic Parkinson's disease. This is a disease that has very characteristic pathological finding, but thus far we don't know what caused the disease. That's why we call it idiopathic Parkinson's disease. You can see also secondary Parkinsonisms, and that means there's a group of diseases caused by a specific known condition. For example, somebody had a stroke, which may cause a vascular Parkinsonism. Somebody had an infection to the brain and then develop Parkinsonism later. That's a Parkinsonism secondary to infectious process. And somebody being on antipsychotics and dopamine blocker can develop Parkinsonism called drug-induced Parkinsonism, and so on. Other conditions here, you can say that normal pressure hydrocephalus is listed as a secondary Parkinsonism as well. We can talk about NPH a little bit more with a little bit more details later. A typical Parkinsonism is a group of degenerative neurological disorders, and they share common features of Parkinsonism, such as bradykinesia, hypokinesia, with posture instability, rigidity, but also each of the condition of single conditions have its own characteristic features. This group of conditions include progressive supranuclear palsy, cortical basal degeneration, multiple system atrophy, and dementia with Lewy bodies. There's another group of conditions can cause Parkinsonism, and this is oftentimes caused by hereditary genetic mutations. In this group, you can say that Park gene mutation called the Parkinsonia syndrome, Huntington's disease, Wilson's disease, and neuronal brain iron accumulation disorders all can cause Parkinsonism, but also cause hyperkinetic kinesia movement disorder, which is it's a much more complicated disorder battle. We can talk a little bit more later on. Now let's switch gear to hyperkinesia. And you remember we talked about this is the group of movement disorders that with the excessive movement. Among hyperkinesia, there are 5 phenomenology defined syndrome. We call it tremor, chorea, dystonia, tics, and myoclonus. Tremor is a type of involuntary movement, and they're typically rhythmic and sinusoidal. It's an oscillation of a body part due to regular contraction of innervated muscles. The frequency of tremor can vary between 4 Hz to 12 Hz or even faster. The amplitude can vary from fine, small tremor to a large, coarse tremor. The tremor can occur at rest and or with action, such as when a patient holds a glass of water in their hand, or when they try to write, or with posture. When you ask the patients to stretch out their arms, you can see the tremor. That's the typical posture tremor. Dystonia is another hyperkinetic movement disorder characterized by sustained muscle contractions that frequently cause twisting or repetitive movement, and an abnormal, sometimes painful posture or position change. And a lot of you may be familiar with the cervical dystonia, and this is those patients, they have their head tilted to one side repetitively. Sometimes can be very painful, and the posture can be awkward, can be embarrassing for the patient. And dystonia typically can be be worse with fatigue, stress, for example, in front of people. Usually disappear when the patient is in sleep or relaxed. Interestingly, dystonia and posture in the involuntary movement can be actually relieved by the so-called sensory tricks. This is a type of sensory feedback, and the patient, her or himself can apply to their body part, and in order to get rid of the involuntary movement. For example, for somebody with cervical dystonia with head tilted to one side, some patients can find that when they touch their chin or some part of the neck or face area, and the sustained movement can get corrected. Chorea is another type of hyperkinesia movement, and it's characterized by very brief, excessive, irregular contraction that are not repetitive, opposite to dystonia, or it's not rhythmic as well, but appears to flow from one muscle group to the other muscle group unpredictably. And this is the condition sometimes when, you guys heard about AFib, it's an irregular heartbeat. Chorea is the rate AFib of movement disorder, and the typical presentation you can classify as it's very irregular movement. And Korea has a distal predominance presentation. Usually, you can see more common in the hands and in the feet, and appears to be purposeless, but maybe disgraced. Like the patient sometimes can try to halfway of the movement and try to come up with that posture action that make it purposeful. This is called parakinesia. Another characteristic feature of Korea is the so-called motor impersistence. If you put your hand in a patient's hand with Korea, you can feel the hand keep gripping and relaxing, just like the milkmaid make a milking. You can ask the patient to stick out their tongue, and you can see that usually you can do that persistently for more than 10 seconds. But for patients with chorea, they cannot keep their tongue out for more than a few seconds. They have to put it back and then stick out again. And sometimes they call it fly catcher sign. Facial grimace and the abnormal respiratory sounds can be chorea as well. So the typical chorea is irregular. There's another type of chorea which is athetosis. It's a like slow motion chorea. It's a class of slow within continuous involuntary movement. Affects usually the distal limbs, and there's a term called pseudoathetosis, and usually describe the distal athetoid movement of the fingers and toes. But it's not due to a basic ganglion disorder, but it's due to a loss of proprioception. Think about somebody hold their hand in the air. Because of the lack of proprioception, the hand is going to try to move around, and it should try to find its own position. That's called pseudoathetosis. Balismus is another type of, it's a faster and violent type of chorea. It's a large amplitude choreic movement of the proximal parts of the limbs, causing a flailing or flailing movement. And remember when we said athetosis is more distal extremities, more slow motion choreic movement. Balismus, on the other hand, is a large amplitude and more proximal parts of the limb involuntary movement. Tics is another type of sudden involuntary repetitive irregular stereotypical muscle movement or vocalization, and the verbal tics. The muscle movement is the motor tics. And as you can remember, we said chorea is very unpredictable and irregular and not repetitive. And tics is usually repetitive, and sometimes you can predict which part of the muscle is going to move. Example of tics would be, repeated eye blinking, facial twitching, head jerking, grunting, slotting, barking, sniffing. Those are the typical verbal tics. Echolalia is a term to describe a patient with tics disorder that they tend to repeat somebody else's words, speech, phrase. Polylalia is the patient's involuntary tics that they try to repeat themselves, repeat a portion of the words or sentence. Corporally is a word and describe that the tics that patient has a tendency to curse, to let out dirty words. Tics as a movement disorder often preceded by a feeling of discomfort that builds up until the tic manifests. In another word, oftentimes patients can tell you they feel the urge to begin with, followed by the movement, then followed by a temporary feeling of relief, they feel better. Oftentimes, this is the type of movement the patient, they can partially, suppress the movement, especially when they are in front of people, but at the expense of mounting inner tension, which is then relieved when the tic is expressed. Tics disorder sometimes can resemble myoclonus when they are rapid and shock-like. But tics can also be very prolonged or complex with motor actions. Those sometimes can be mistaken as dystonia. Myoclonus is a type of hyperkinetic movement with a feature of sudden lightning-like, shock-like muscle contractions. It can be focal, it can be monofocal, or generalized, involving the whole body. Usually random and irregular, and with a jerky feature. Unlike chorea, this movement don't flow into one another. All right, in summary, hyperkinetic movement disorder, if you put them together, you can see that this is actually a spectrum of different, speed, amplitude of movement, with myoclonus be faster, violent, and jerky-like, and Balismus is a little bit slower. Chorea is even more slower, and then athetosis dystonia is a much more smoother and more flowing, more sustained. And these movements are differ from tics in that they cannot be suppressed, while tics can be monetarily controlled. All right, that's just an overview of the common phenomenology of movement disorders. If you have any question, please feel free email me and also the program, so we can get your questions answered. Thank you.